academia's response to it, the medical community's response to it, and some of my colleagues' response to it, so unsettling. I mean, I've been, and maybe this is, maybe there's an idle piece of it, but I've been very proud of being a doc and, as a Christian trying to represent our field with excellence for the last 40 years. I am embarrassed and ashamed at how our profession has dealt, with this issue when we are talking about, at least in the context of like the kids that we serve, the most vulnerable kids and families in our population. And so, as Brian shared, I got asked to talk about this several weeks ago at Christian Alliance for Orphans, and the theme of the conference was distinct. And so, in a time when this issue has become very politicized, thought to myself, preparing for that conference, how do we affirm what is true, when it comes to kids dealing with gender dysphoria? How do we affirm what God's design is for kids as embodied souls who are all image bearers of His? How do we affirm approaches to treatment that actually promote and advance the health of our patients? And how do we affirm the ethical principles that have traditionally undergirded our profession while providing care the best we know how to, for kids who are struggling with gender dysphoria and their families? So our learning objectives today is that I want to give you sort of a feel for what these kids look like. We'll talk a little bit about like what we know in terms of the clinical presentation of children and adolescents with gender dysphoria. Talk a little bit about some of the other like developmental issues, psychiatric comorbidities, and I'll share a little bit about like what we've experienced with this in our own practice. We're going to take a look at the evidence base for quote unquote gender affirming care in youth with gender dysphoria. We're going to take a look at some of the ethical principles that really ought to guide us in terms of like the nature of our interaction with and care for these families. And spend a little time talking about like, well, what do we say to patients and their families, in the environment that we're in, talking about, what appropriate treatment is and isn't, while we have to navigate the relationships that we have, with our colleagues, with our supervisors, if you're somebody who's in training or resident or a fellow. And given the fact that the vast majority of us now are employed by large institutions that are, that are offering, gender affirming care, how do we navigate some of these environments and do so faithfully? And, how can we be Daniel, and how can we be Shadrach, Meshach, and Abednego? And honor God and do so faithfully and with fidelity in the context of, what is very much a hostile culture. One conflict of interest that I'll mention with regard to this, and a project that I was involved in, a wonderful resource for families that are struggling with this, is the Colson Center put together like a very extensive video library called the Identity Project, that gets into issues, from a biblical perspective around, gender, sexuality, and is intended to be a resource for families, churches, Christian schools, specifically in terms of like how we understand best identity in the context of our culture. So there are all kinds of different controversies around this issue, and let me touch on a few as we prepare to kind of dive in and like look at like what's out there in the research literature. One of the statistics that you'll hear is that 80 to 90% of kids who present with gender dysphoria will eventually outgrow it. This is a result of, a fairly substantial body of research from a guy, he's a child psychologist named Ken Zucker up in Toronto. He was the person who wrote the chapter on gender and sexuality in the DSM-5. And interestingly enough, again, #1 guy in the world when it comes to research in this, and had his clinic in Toronto shut down by activists in 2016 because he at that point was recommending supportive therapy as an appropriate treatment for these kids. One of the questions we have to look at is that, and we'll get into this in a little more detail, is that there's an enormous disconnect between the way our professional societies here in the US and the health authorities, particularly in Europe, are viewing appropriate responses and appropriate care for these kids. In terms of what is evidence-based care and what is not. So at the same time, a number of countries in Europe are radically restricting access to gender-affirming care. In the case of like the UK, shutting down the clinic that was serving kids from across the United Kingdom, kids covered by the British Health Service who were seeking this kind of care. At the same time they're shutting down their clinics, there has been an explosion here in the US in terms of the number of kids who are identifying as transgender. And until the current administration took the steps that they did several months ago in terms of threatening funding cuts to hospitals that continue to do this, we've embraced a very different approach here. We need to look at why that is. One of the things that is rather unsettling is that historically, again, if you take a look at kids who are described in the research 2015 before, it's a very different profile. That the way that this was thought of before was that the majority of kids who, again, pre-2015, who were presenting with gender dysphoria were male. They were elementary school age kids. They were younger kids. And that this was something that oftentimes they had experienced over a period of years. With the opening of all of these gender clinics, the increase in awareness about this issue, there was this explosion of kids who were identifying as transgender. Oftentimes, again, without sort of this lifelong history, that people had seen before. I think about the first kid that I had in my practice where this was an issue. Was an adopted kid, all kinds of trauma. It's probably about the number 4 thing on our problem list at the time. But sort of the classic sort of paradigm, what Zucker would have described in his research, is that when his family brought this kid in, it was the biological daughter, but things the African American kid that had sort of a crew cut, played on the boys soccer team because quite athletic. And one of the things when the family came in, would bring pictures, and they'd have a family wedding. Their daughter would be more comfortable wearing a shirt and a tie, to go to the wedding. Sort of, the traditional thing that we would see. In more recent years, you would have kids who would be declaring themselves this way, without there being any history of gender confusion or dysphoria from when they were younger, and that's part of what are presenting to these clinics. So is this notion of rapid onset gender dysphoria, as some people have described it, a valid clinical construct? One of the questions, and talking about Jonathan Haidt's work and anxious generation and the explosion in the rates of stuff, how much of the rapid increase that we've seen in kids, describing themselves as transgender is a function of the internet, social media, and a component of social contagion in terms of spreading this? And then one of the things that I was involved in for CMDA nationally is that there's this case now pending in front of the Supreme Court. There are 22 states that have passed laws prohibiting professionals from engaging in quote unquote conversion therapy. And so, one of the way that this has been interpreted in a number of states is that these families and these kids come for help to do anything other than to encourage them in this identity that they have embraced, can be viewed as, in some cases criminal conduct, and in some states it's viewed as an ethics violation and something that will get your license taken away as a profession. So one of the things the Supreme Court's looking at, and that CMDA certainly commented on, is the appropriateness or inappropriateness of these laws, and whether it's actually hindering our ability to provide good care as opposed to being helpful. So this is a graph looking at referrals to what would have been the Tavistock Clinic, which was the one clinic in the UK where kids were sent, specifically for treatment of gender dysphoria. And again, you go back and you look at these numbers. 2010. I mean, we're talking about, again, the entire UK. You're talking about 100, 125, 150 kids. Well, over the next 10 years, there was a 40-fold increase in the number of kids being, referred for this care. And what changed over time, again, is that before that this had been elementary school-age children, increasingly, especially after you hit 2015 was Caitlyn Jenner, when our former Olympic decathlon champion, decided to start living as a woman, you see a very rapid uptick. And what's interesting is that from that point on, it's now, again, primarily adolescents as opposed to younger children, primarily girls as opposed to boys, which was another change. Although in the most recent data from the US, maybe that's starting to even out a little bit. And again, these extraordinary increases in the number of kids who are seeking care. Now, when I was preparing my slides for the CAFO conference earlier this month, one of the things I decided to do was to do one last minute data check and see if things need to be updated. And there's the Williams Institute, which is associated with UCLA's law school, has put out reports periodically based upon the most recent data from the National Youth Health Risk Survey. And if you compare the release at the end of August of 2025, which is based on data that was collected at the end of 2023, over a 3-year period of time, we saw more than a doubling of individuals in the US identifying as transgender. We went from, in 3 years' time, 1.3 million to 2.8 million kids and adults identifying as transgender. There was a 240% increase in 3 years in terms of the number of kids who identify as transgender. A 2022 report, there were 300,000 kids nationwide, 732,000 as of the most recent data. It was released at the end of August. One of the other things that changed was even as late as 2022, this was largely a regional phenomenon. So that like the rates of kids identifying as transgender, if you looked at the Northeast, New York area, Washington, DC, Illinois, California, Washington, Oregon, was 3 to 4 times the rate you saw in the rest of the country. That is no longer true. and the rates at which teenagers are identifying as transgender, is pretty much identical now, regardless of like what state or region you're from. You heard the statistics with autism. It is now 1 in 30 teenagers, 13 to 17-year-olds, identify as transgender. Rates are slightly higher in kids who are biracial and white compared to the rest of the population. But again, 240% increase in 3 years. Now, one of the questions that comes up, and one of the arguments that proponents would make, of gender affirming care, is that the reason why we're seeing so many people is the fact that it's increasingly become destigmatized. And that people are more comfortable now, disclosing that this is their identity. But what's interesting when you look at this is the age distribution of folks who identify as transgender. That of these 2.8 million Americans, more than half of them are between the ages of 15 and 24. The other thing that you will notice here is that in terms of like the older population, particularly when you get into folks north of age 50, the percentage of older adults who identify as transgender has not changed one iota over time. And so part of why this 15 to 24-year-old group, or 13 to 24-year-old group, when you start to think about it, is, go back to like your psychology 101. What's the primary developmental task of adolescence? It's identity development. And what may be unique about this is that, one of the things I tell parents, like Christian parents all the time, is like, everybody's an atheist in 9th grade. Kids go through different phases, like, they'll go through like the goth phase or the stoner phase, but they try different things on, feel like, sort out like what feels comfortable for them, and that's part of how kids, go through the process of forming identity. What seems to be different about this, and some of it may be because of all of the affirmation, some of it may be because of secondary gain in the role of the parents, some of it may be because of the comorbid mental health conditions that they have, is that when they land on this, there seems to be sort of an effort to cement them into it, I guess would be sort of a good way of putting it. Now, one of the reasons, like, Brian mentioned earlier that he saw me talking a little bit about this at one of our conferences. And one of the things when you start sort of like digging into this is that among adults who identify as transgender, disability is far more common than in the general population, and even far more common than it would be in the LGBTQ part of LGBTQ. So this is actually data from the Human Rights Campaign that's very much a champion of this. And when you look at like all kinds of like, non-mental health related disabilities, cognitive disabilities, hearing loss, capacity for independent living, capacity for self-care, vision, mobility, the percentage of adults, who identify with these conditions, who have these other disabilities, is far higher than the LGBT population, and orders of magnitude higher than like what you see in the general population. This is a study looking at the prevalence of other neurodevelopmental conditions in adults who identify as transgender. This is a population study out of the UK, looking at around 200,000 adults. And so, when this first started to become popular, like one of the things that we do sometimes, when there's something that looks different in like child psychiatry, looks different in medicine, and we're trying to figure out like what to do about it, is we ask ourselves, like, is there anything else that we treat that this kind of like reminds us of or resembles? And so, in my mind, there were like 3 or 4 different conditions that came to mind when we started like thinking about this, and where there were similarities to patients with other issues. Um, one of them was, one of them was anorexia, because that's another condition typically that we treat, where, it was not uncommon for kids to have sort of this gross distortion, in terms of like, the reality of their, the reality of their physical appearance and their physical being, compared to like what they had internalized. Another condition that, kind of looks like this a little bit is body dysmorphic disorder. I had a couple of these patients where they already started as teenagers going down the road of having different types of like plastic surgery done. They're great looking kids, but in their mind, my nose doesn't look right, my, breasts don't look right, blah, blah, blah. The other thing that, it looked like, because of the delusional quality, of some of the thinking, and the disconnect between their perception of being either male or female, versus their genetic makeup, is folks with psychotic disorders. And so, like, when you look at this, again, in adult population identified as transgender, they are 5.5 times more likely to have an autism diagnosis, 6.5 times more likely to have an ADHD diagnosis, nearly 4 times more likely to have a depression diagnosis, 5 times more likely to have a bipolar disorder diagnosis, 3.5 times more likely to be identified with a learning disability, 5 times more likely to be identified with OCD, and 29 times more likely to have been diagnosed with schizophrenia. And so one of the things that you hear about that has made this so controversial is that, like, again, even compared to like the LGBT community, like, their rates of suicidal behavior are like exponentially different. And these folks are at exquisitely high risk, and part of it is because of just like this morass of mental health conditions that seem to accompany this. When you look at like more recent research, like out of the U.S., and this was in a school psychology journal, that 70% of kids identified, met criteria for having anxiety disorder, nearly 60% depression. Over half of them regularly engaged in non-suicidal self-injury, and nearly half of them met criteria for PTSD. One of the other differences, like when you start looking at the T kids versus the LGB, is that they're significantly more likely to have experienced significantly more trauma. So that, the T kids compared to the LGB, more emotional abuse in their history, more physical neglect, more emotional neglect, and that a little less than 20% of the variance overall in their mental health compared to their LGB peers was thought to be directly related to the adverse childhood experiences that they had been through. Here was the one that, and it was this particular revelation by some whistleblowers in the UK, who were concerned about what was going on clinically at the Tavistock Center, which is where they were sending these kids from all over the country. This was one in particular that very much, kind of like resonated within our disability ministry community. And one of the things for me where the alarm bells really started to go off. So that there had been, again, these whistleblowers went to like some of the larger newspapers in the UK, and when they started digging into, some of the outcomes data from this clinic, it turned out like part of their assessment involved an autism screen, and that 48% of the kids in the UK who got either puberty blockers or hormones qualified for an autism diagnosis, with 35% of the kids who got either puberty blockers or hormones having what we would consider level 2 or level 3 autism. And so that if you were a kid, like, between 2010 and 2018 in the UK, if you had autism, you were 17 times more likely, to be treated and to get gender-affirming care through Tavistock Clinic, than your neurotypical peers. Here's an interesting study from the US, and again, like, one of the issues with, and we'll touch on this in a couple of minutes, when you start looking at some of the population, some of the research that's out there, is that I like to gravitate toward like larger population studies, and this is where I'm not a big fan of socialized medicine, but in European countries, having everything in a single database really helps you to collect information. The closest thing that we have to that here in the States is that they looked at a database of kids whose parents were covered by military health insurance over a period of 8 years. And so that they're looking at mental health care utilization in kids who identify with, being transgender, having gender dysphoria. The control group were their siblings who had not been identified with gender dysphoria. So that the kids, again, with gender dysphoria were 5.5 times more likely than their siblings to have a mental health diagnosis. They used way more mental health services, were on far more psychiatric medicine. The interesting thing, and part of why I'm sharing this, was that while the gender affirming care is supposed to promote their mental health, they were on 67% more medicine after that treatment was initiated than they were prior to beginning the gender affirming care. And so part of when you're trying to look at the research here, some of the considerations that you have to ponder is, we don't have a really good model right now for explaining why we're seeing so many more kids with this. Like, what do we think causes gender dysphoria? What's the nature of gender dysphoria? I mean, is this a normal variation in development? Is it a social construct? Is it a mental illness? Like, from a biopsychosocial cultural standpoint, how do those different factors come into play in causing this? What role does the physiological changes taking place during puberty play in development of gender identity? What role do these comorbid mental health conditions, and comorbid medical conditions play? What are the risks and benefits, of choosing to undergo or not undergo, these medical interventions? When is a kid old enough to be able to give informed consent to any of this stuff, particularly when we're talking about treatments where there's a very substantial risk of, eliminating, the potential for future fertility, and the whole social context in which all of this stuff is being perceived. And so there was a lot of research here in the States, under the previous administration, that was getting funded. But what they're looking at in some of these meta-analyses that I'm going to be pointing to in a minute is that there are a lot of small, very short-term studies. And this gets really, really messy because of sort of the conflicts of interest and agendas here. So that, one of the things that gets drummed into your head, how many med students do we have here today? Okay, one of the things you hear, drug companies are bad, drug companies are evil, research that they fund is all biased. Well, there are lots of different biases that can contribute to research. Some of the more prominent people in this field are folks who publicly identify as being LGBT. And, within their community, that working on this and demonstrating that this is a beneficial thing to kids, comes with a great deal of status and prestige and recognition. Sort of in the same way that within the Christian community, if I were able to do a study and show that, that abstinence and Bible study and going to a Christian school raised healthier kids, that there are certain benefits associated with that. All these researchers are working for institutions, and most of the institutions that they are working at have these gender clinics open where there is a significant financial incentive to the institution to prove that what they are doing is effective. The other thing is when the government gives you research money, the government has objectives too. And so, when you're looking at folks who are, tenure track kind of faculty, where, they need to be getting, NIH kind of money, giving the funders the results that they want is important to you in terms of being able, to maintain your funding stream. We talked about before, are we comparing apples to apples and oranges to oranges? And are the kids who are getting enrolled in research studies in 2021, 2022, 2023 comparable to the kids that we were looking at in 2010, 2011, 2012? And again, because of the fragmentation of databases, it's very difficult to look at this stuff here. And so the work that a lot of people point to, that's sort of like the seminal work that's been done in this area, involves something called the CAS review. And so when these whistleblowers came forward in the UK and the papers were reporting what was going on, the government, British Health Service shut down this clinic. They commissioned an independent review of the literature, to try and figure out what's the best way for us to be serving and taking care of these kids. And so part of how, when they do this in the British Health Service, the review is overseen by a physician from a different but closely related specialty. And so Hilary Cass is this very famous, universally sort of renowned and regarded pediatrician in the UK. And so they put together this whole work group together, and they commissioned 8 systematic reviews of the evidence regarding gender-affirming care in children and teens. All of these were published in 2024 in the Archives of Disease in Childhood, and the articles were updated this past December. There is also, again, a very comprehensive review that if you downloaded the slides, I have a link to the download in there. And so one of the reviews is that they're looking at social transitioning. So this is the, dressing as if they are of their preferred gender. This is the pronouns, preferred name, looking at all of that stuff. 11 studies were included. Most were described, and these are direct quotes from the papers, the meta-analyses in the CAS review, what you see on the slides. Difficult to assess the impact of social transition due to the small volume and low quality of research. No prospective longitudinal studies with appropriate comparator groups assessing impact of social transition on mental health or gender-related outcomes for children and adolescents. Professionals working in the area of gender identity should be aware of the absence of robust evidence of the benefits or harms of social transition. Puberty blockers. No high-quality studies were identified using an appropriate study design to assess the outcomes of puberty suppression in adolescents experiencing gender dysphoria or incongruence. Insufficient and or inconsistent evidence about the effects of puberty suppression on gender-related outcomes, mental and psychosocial health, cognitive development, cardiometabolic risk, and fertility. Where they did have consistent moderate quality evidence was that bone density and height might be compromised in kids taking puberty blockers. Quote, a lack of high quality evidence to support the use of puberty suppression in adolescents experiencing gender incongruence. Cross-sex hormones. Again, just ditto. Lack of high quality research assessing the outcomes of hormones for masculinization or feminization. Limited or inconsistent evidence regarding gender dysphoria, body satisfaction, psychosocial cognitive outcomes, fertility, height, growth, bone health, cardiometabolic risks. A lack of high quality evidence to support initiation of hormones for masculinization or feminization in adolescents experiencing gender dysphoria or incongruence. The suicide issue, and where the experience that a lot of folks have reported over social media, and sort of the classic line, would you rather have a live son or a dead daughter? Which was sort of like what parents were hearing when they were going to these clinics, and the clinicians who were seeing their kids were trying to sell them on these interventions. The evidence supporting either lower or higher suicide rates in kids receiving gender-affirming care is insufficient. It is true that the proportion of suicides was higher in kids who got referred to the gender clinic, but that difference went away when they controlled for access to specialty care in terms of child and adolescent psychiatry for treating the comorbid conditions that they had. And one of the points that they made is that, again, suicide rates in these kids were high, but again, still relatively uncommon. So that the adolescents who identify as being transgender, they're 7 to 8 times more likely to attempt suicide, 3.5 times more likely to die by suicide, and twice as likely to die from non-suicide related causes. But again, that rate wasn't significantly different than the kids with gender dysphoria who did not undergo the gender affirming care. There was a 30-year study in Sweden where they looked at long-term outcomes in terms of adults with gender dysphoria who actually went through surgical procedures. And while there were certain measures in that study, again, this is adults, where showing more positive mental health outcomes or improved happiness, sense of well-being, the suicide rate was no different in those folks as opposed to the ones who didn't receive medical care. And ultimately, in that 30-year study of adults in Sweden, they were 18 times more likely to commit suicide than other adults in the general population. And so that, if you were working in this area, what they found in the UK is that you would have to treat a little over 1,300 kids who identified as being transgender for a year to experience one who committed suicide. Now, piggybacking on this, shortly after the change in administration, the U.S. Health and Human Services, commissioned a review of the evidence here and best practices, largely based off of the same stuff that they looked at with the CAS review, and again that they came to similar kinds of conclusions here. That their review highlighted a growing body of evidence that pointed to significant risks, including irreversible harms such as fertility, while finding very weak evidence of benefit. And that despite increasing pressure to promote these medical interventions, the review said that the science and evidence don't support their use and that the risks can't be ignored. And this is why HHS took the actions that they did around funding with our pediatric hospitals that we're doing this. And so how do we make sense of this enormous disconnect between all of these different health authorities across Europe putting these restrictions on access to gender affirming care, in terms of banning it altogether, limiting it to kids who were in IRB approved types of research protocols, versus what we see here, where the American Academy of Pediatrics, the Endocrine Society, American Academy of Child and Adolescent Psychiatry, have all championed this stuff. One of the things that they looked at in the CAS review is that they actually did a systematic review of the clinical guidelines that had been published by different professional societies around youth with gender dysphoria. So they looked at the WPATH guidelines, American Academy of Pediatrics, they looked at Endocrine Society and some others. And the points that they made was that few of these guidelines were informed by doing actual systematic reviews of evidence. There is a lack of transparency in most of these guidelines in terms of how the recommendations were made, and that in particular, the WPATH and the Endocrine Society guidelines were highly influential with these professional societies, but those guidelines themselves lacked developmental rigor, and that again, basically, it was the same people involved with the different organizations, and that everybody was co-sponsoring one another's work that wasn't based upon sound science. So you're a Christian health professional, and they will, this issue sooner or later will find you. Part of how I got interested in this, I was teaching, I used to, before speaking out on this, used to have an opportunity to regularly teach evidence-based medicine or at my alma mater. I gave our students an assignment like that, 2 moms come to you as their trusted pediatrician, to ask you about sort of the safety, long-term safety and effectiveness of a recommendation that they got, from the gender clinic at Akron Children's after their 14-year-old adopted son or daughter who now believes that she is their adopted, son, after a 4-month period of time of adhering to these beliefs. And the question was they're asking you, are puberty blockers safe and effective long term? So part of what we're doing with the assignment, the purpose of the assignment is that we want, our students to be able to, to go through the research literature and look for studies and look for research that's appropriate to answer the question at hand. So the things we're looking at is it the right problem? Is it the right patient population? Are they describing the right intervention? And so, part of the assignment was that they had to send me one of the articles that they were going to discuss, and it was about using puberty blockers for precocious puberty. And, I kind of sent them a nasty email and reamed them out for that because, very different problem, very different patient population. So that was a Friday. Next day was a Saturday. I spent 3 hours on PubMed and couldn't find anything that was relevant, which was a real eye-opener. So we're getting together, then for our meeting where we're discussing this. And, since there wasn't any data, I sent them 4 papers through. One was the American Academy of Pediatrics guidelines. One was the Endocrine Society guidelines. One was a post from the head of evidence-based medicine for the British Medical Journal, basically where he said all of this stuff is crap. And the other was a paper by Dr. Robert Malone, who started the Society for Evidence-Based Gender Medicine, where he goes through the AAP guidelines reference by reference and paper by paper, and specifically cites how they misinterpreted the evidence. So the question I asked them is, how do you reconcile what you found in your literature research with what these professional societies are saying? I mean, most of these students, they're pretty woke, but they're sitting there with their mouths hanging open at this point. And so, again, it's unsettling on so many different levels because, one of the things that we teach our students and we teach our residents is, trust your professional societies, trust the institutions, trust clinical guidelines. And it appears in this case that all of that got hijacked by a very different agenda. And so, so in the environment that we're in, some of the questions that we have to be asking ourselves is this treatment ethical in terms of how we understand the traditional ethics that have guided our profession? is this treatment consistent with the purposes of medicine? Why do we all sign up for this, and why do we do what we do? The most common question that I was asked in my 40 years in practice is, Dr. Grcevich, what would you do if this were your kid? And part of what we have to ask ourselves is that, that it is so easy for us to become so compromised in the environment that we're in. Is the way that I'm responding to these patients, or the way that I'm responding to the expectations of the institution where I work, causing me to violate a biblical principle, aka sin? A big part of, when I think about part of my role, and we were talking about identity earlier, as a Christian in the medical field, part of my witness is that we represent an excellent God. And so that if I can do my work with excellence, that is a reflection on my Lord and Savior. This violates just about every principle that sort of guided my training as like a psychiatrist 40 years ago. Part of how I was taught as a resident to understand my role is that part of our job is to affirm and promote healthy reality testing. That Jesus said, I'm the way, the truth, and the life, and that part of how, again, as someone who had the opportunity to dabble in some research, is that my job is to point people to truth. I have never encountered anything scientifically that was in contradiction to my faith, because again, Jesus says, I am the way, the truth, and the life. That there's that there's a created order. He wants us to explore that created order. But I tell folks, I don't agree with my patients with anorexia that no, you need to lose more weight. That if a kid walks into my office and declares himself to be Jesus, I am not bowing down to him, and referring to him as the Messiah. So why are we dealing so differently with this problem? And are we in fact, when we start using preferred pronouns that are directly in conflict with biological reality, are we bearing false witness? And so let me talk about sort of the ethical stuff and sort of like our historic ethical principles pertaining to this kind of care, and sort of like running it through the filter of these kids. So that, the ethical principle, when you look at like the folks who run our professional societies and the academic medical centers that people seem to embrace nowadays, is the importance of allowing patients to exercise autonomy. And that as long as it is legal and technologically possible, that people have a right to whatever care services they determine are best for themselves. And that because we have licenses, we have a responsibility to support them in exercising their rights. But let's talk about autonomy for a minute, the ability to make a decision for yourself. At what point is a minor capable of assessing the risks and benefits, of puberty blockers, cross-sex hormones, with potential for serious long-term adverse effects? When the British Health Service says that when you look at the literature, it's not possible, to be able to, to fully, comprehend some of the risks and the benefits. So part of being able to exercise autonomy is informed consent. So when these kids are being seen in these clinics, you know, is, what they are being asked to consent to. Are we giving them the kind of accurate evidence-based information that would allow them to exercise their autonomy? The second principle is beneficence. What quality of evidence do we have that shows that any of this stuff helps? Where are the demonstrable short and long-term benefits? They're non-existent. They're non-existent. Then we have non-maleficence, like do no harm. Like if you remember hearing that at like some point in medical school. What are the long-term effects in terms of fertility, sexual functioning, bone health, cardiovascular risk? We have no idea, and again, we're starting to see increasing numbers of folks, and I was just like, on an email chain where they're looking for, and I do some stuff with Focus on the Family, they're looking for docs to get together to create a network of professionals nationwide to support people who are detransitioning. And then there's the justice issue, and you look at the impact of this in the disability community. And when I was going to tell you like a little bit of like what we've seen in our practice, and that one of the psychologists, I didn't necessarily see a lot of these kids myself, but for my main psychologist, this became the majority of the work that she was doing close to the end. What we saw in our practice was that these were almost all girls, almost all very bright, not necessarily conventionally physically attractive, so that our Instagram models are not getting confused about what gender they happen to be. And that a lot of these kids were either on the high end of the autism spectrum, or they had issues with anxiety or rumination, where once they got a thought into their head, compared to other kids, they would have a much more difficult being able to let it go. One of the most disconcerting things that I heard, I posted some about this, and some of you are familiar if you follow social media with Billboard Chris. The guy who travels around the world with this sign, saying children can't consent to puberty blockers. I posted something about this, and he sent me a response, and he said that in a number of cities that he goes to, that the nonprofits that are supporting and working with the autism community are actually funding the gender clinics for kids in these cities. And so again, you have the most fragile of our fragile kids from a mental health standpoint, who appear to be more vulnerable to getting sucked down this road. And so, at a core level, I mean, like, this just tugs in so many different directions. And some of you guys are familiar with Far Curlin. He did like CMDA's like regional thing, I think, last month up in Michigan. Medical ethicist from North Carolina, has talked about the fact that, this issue is linked to other things too. So that when you start looking at sort of this notion of the purpose of medicine being, that we're there to help people exercise their autonomy. This is the same thinking from a medical ethics standpoint that supports, late-term abortion, post-birth abortion, which is something that you may have heard about, that's been written up in some of our journals. And the whole medical assistance in dying thing in Canada, where because of the legalization of physician-assisted suicide, and the Ontario Medical Society saying that it is unethical to refuse to kill your patient if they ask you to, or to knowingly refer them to someone who will, if they qualify under the law. All of these issues that fly like right in, that fly in the face of our traditional understanding of medical ethics, and that fly in the face of, the created order in biblical teaching. like this isn't why I think any of us like went into medicine. That how is what we are doing with these kids helping to promote health? And it's not. But the pressures are so great that most docs, and this is one of the things we have to be sort of self-aware of, that we are where we are because most of us are exemplary rule followers. You get into medical school and you get into a residency because we're really good at pleasing people in positions of authority. That you got great letters of recommendation to get into med school. You got great letters of recommendation to get into your preferred residency. And that all of our institutions appear to be behind this stuff. And so the guy up on, how many of you know Alan Josephson? I used to work together with him fairly closely when I was involved with some stuff with the Child Psychiatry Academy. The guy, top 100 to 200 child psychiatrists in the world. Started the Child Psychiatry Division, was an endowed professorship at the University of Louisville. Got fired in 2017 when he gave a lecture in Washington advocating for supportive therapy as a treatment for kids with gender dysphoria. Ended up winning a large settlement after 7 years in court, but he's never gonna practice again. There is a price to bucking your institution with this. And for whatever reason, we can be pro-life about a lot of other things, but this is literally the third rail. I can tell you personally that the week after the Identity Project came out, I got an email from the course director of evidence-based medicine where I teach, saying, don't worry about your sessions this week, we've got them covered. And I have not been invited back since. It's safe to say that, people who take a strong stand on this, it was really funny. I got some message from a recruiter after in children's, are you interested in the position? I go, you might want to Google me first. And so, so what responsibility do we have as Christians to represent the data that's out there with integrity? And again, I think that part of why the CAST review is so valuable is that this area, again, this top area of medicine has gotten so politicized that it's very hard to argue that something commissioned by the British Health Service is sort of like an agent of MAGA, and for the people in positions of authority to look at it, specifically in that way. And so, we were doing, and I also found this to be kind of unsettling. There was one of my very courageous colleagues who was part of the psychiatry section at CMDA was presenting this week at the ACAP meetings on the CAST report. And so there was an evening Zoom call with people in the psychiatry section of CMDA. And let's just say I found the level of cowardice on the part of some people in the group kind of concerning. And, one of the things, it teaches us in scripture, if you're going to follow Jesus, be prepared to count the cost. And that there's a guy that I work with and help to, sort of support and supervise, who's actually a clinical faculty person here at Case in the nursing school, psychiatric nurse practitioner, had been a biblical counselor with Fieldstone, who, jumps into conversation and said, Shadrach, Meshach, and Abednego had their minds made up about who they were going to honor before Nebuchadnezzar asked them to bow down before the statue. And so, you got to decide for yourself, what are you going to do with the pronoun thing? Dead naming, in patient interactions, what you put in people's charts. what kind of clinical recommendations do you make to folks when, they're coming with you and asking you for advice about your kid, or where you should refer their kid? If you're in an institution that requires you to send them internally, and you know that the person that they are going to be sent to is going to support this message. And I think that, with this issue, and it won't be the first for those of you who are younger in the space of your careers, like, how do you need to think about putting yourself in a situation where you can be faithful to Christ, and where you are prepared to be able to practice with integrity, which is getting increasingly difficult. And so, one of the things that finally motivated me to say something is that, my daughter and son-in-law, are residents at Mayo Clinic. Both of them, I think, are probably going to be stars, relatively speaking, within their specialty. They're going to have to make some really difficult decisions going forward. And it has already impacted my son-in-law in terms of some things that he might be able to do career-wise, because ethically, he's going to be a surgeon. He's cool with doing redo surgeries of, folks who are coming in there because somebody else got this really messed up. But he's not good as a Christian doing this for the first time, and that precluded him. They were bugging him to do a plastics fellowship and other things, and it closes certain doors. And so, how can I ask or expect them to do something that their dad isn't willing to do or doesn't have the guts to do himself? And so that I think that it's important for those of us who are older, who have less at risk, and have maybe been through like the Bible a couple of extra times, that we have a responsibility to mentor our younger colleagues, and that we have a responsibility to be the example that we want the next generation of our profession to follow. So again, Phil, I am grateful for the opportunity to share today, but to kind of like close this part off, the kids that we're talking about, it's not just statistics. These are the messiest kids that we see in our practice when it comes to, being on a high end of the autism spectrum, complex patterns of mental health comorbidity. They're clearly the most vulnerable. That we view this very differently here in America than they do in Europe. And perhaps during sort of our follow-up discussion, we can talk a little bit about why. But the whole issue sort of illustrates how, in a lot of ways, I think that our field has lost our way in terms of, sort of forgetting what the purpose of medicine is and how what we do should be understood, within the context of Western culture. And that, to be able to practice in a way that is in integrity with the created order and in integrity with our faith, you will face multiple ethical dilemmas trying to do that within the context of our system. I know I ran over a little bit, but I thought this is an important topic. I can either stop now or we can do questions as part of like the panel, whatever works best for us.
Yeah, let's take a break and then we can.